Good morning. Can everyone hear me in the back? Yes, great. So I hope you guys are enjoying yourself and learning a lot when it comes to men's health. What I plan on doing is adding a little knowledge to your repertoire about heart disease. I've been tasked to speak to you about how do I know when it's the big one. So we'll take a few minutes of your time and have a question and answer session at the end of the presentation to try and deliver that information to you. So we want to treat this lecture as a guide. We want to give you a guide to a better, longer life, healthier life. We want you to try and prevent heart disease, and we want to give you the tools to try and do this. And using this guide, of course, we want to express that when it comes to healthcare and medicine, it's not an X, Y, Z process. If you do X and Y, you will definitely end up at Z. Over time, what we plan on doing is reducing your risk of having these problems, heart problems, heart attacks, and congestive heart failure. And of course, with a risk, the risk is never zero. And so that's what we're tasked to do. One of our missions and our goals is by 2010, we want to reduce cardiovascular disease in this country by 20%. I don't have an update on where we stand with that goal, but that's one of the things that we want to do. Cardiovascular disease also includes stroke as well. So heart attacks and stroke is our focus here. Heart disease, again, is the #1 killer of men and women in this country. We definitely want to focus on reducing that number. And just as this guy tried to change his position over the summer, we want to try and change our position from at least #1 to drop that. We don't want to be the #1 killer in this country. So warning signs of heart disease and heart attacks. The biggest first thing that people talk about is chest discomfort. Now, chest discomfort means different things to different people. Some people describe it as a pressure in their chest, which can be sometimes mistaken for gas or acid reflux. Some people have a bloating, a fullness in their chest that they complain of. They think it's gas, but in reality, they may be having a heart attack. And vice versa. Some people feel they're having a heart attack and find out that they just had a lot of gas there. Other things that the chest discomfort can mimic, sometimes it can be a sharp pain. Usually not associated with sharp pain, but it can be. Different people have different sensations. So one person's heart attack symptoms won't be the same as another's. Some of the other things that are associated with it, shortness of breath. If you're having some chest discomfort, whatever way you describe it, and you can't breathe, that's a major sign, and you need to seek medical attention emergently. Other things, nausea, vomiting, uncontrolled sweating, fatigue, all these are signs that you need to seek help. Now, some of the risk factors, again, in medicine, risk factors, percentages of things happening, these are things that we want to bring to your attention. Things that you can't control or things that you can't change. As you get older, the risk of having heart disease, strokes, heart attacks goes up, and that's something you can't control other than stop getting older, and who wants to do that? Just being a man brings along a higher risk of having heart disease. Usually men who are at highest risk for having heart disease can start having problems in their 50s, whereas women, they don't start having problems that we generally see until after menopause in their 60s or so. But shortly thereafter, in their 70s, they catch up with the men as the risk of heart disease and stroke. Race, anything, some ethnicity groups just have higher risk of having these processes. So these are things that you can't change. Some of the things that we can, one of the biggest ones on here is tobacco. People who smoke. This is one of the biggest things that you can do to lead not only less risk of having heart disease, but to cancers and strokes as well. Other things that play major roles: cholesterol levels, blood pressure levels, and controlling your diabetes. In cardiology, we kind of call that the trifecta: high blood pressure, diabetes, and having high cholesterol. Some other contributing factors: stress. I have patients come in and say, "Doc, I'm just stressed out, I'm having problems, I'm having a heart attack because of stress." Well, stress contributes, and the way the stress contributes is it leads to a higher level of anxiety. Your body secretes higher level of certain hormones that actually drive you to have higher blood pressure. It drives you to have worsening diabetes, and actually makes your cholesterol levels worse to control. So obviously you want to have control over your stress levels in a healthy manner. Everybody gets stress. It comes with just being alive and functioning well on this earth, but you have to be able to control it. And you don't want to turn to things as alcohol or drugs or things of that nature to manage your stress. Diet and exercise, again, I tell all my patients we live in South Louisiana, and we always know that's a struggle. Symptoms. So we have mentioned thus far about shortness of breath, which is the medical term is dyspnea, and chest pain, whether your pain is a discomfort or pressure or sharp pain or ache or ag or however you describe it. But palpitations. And palpitations can be described as you just feel your heart beating heavy, it's pounding, or it can be racing. But generally speaking, most people don't feel their heart beating at rest. Sometimes I've had patients that say, "Doc, you know, when I'm laying in bed on my left side, I just feel my heart beating." Well, that's pretty normal because your heart's on your left side, and when you lay there, it kind of comes against the chest wall. So if anybody has that, they're fine. But this palpitations and abnormal feeling heart beats can be something that's abnormal, and you should seek some attention to try and get that addressed. Now, angina. You may have heard this word before. Angina is a medical term for what most people say is chest pain or chest discomfort. And so angina or angina, generally speaking, occurs in the center of the chest. And under normal circumstances, angina occurs with exertion. So the more activity you do, the more discomfort. If you stop and rest, that discomfort starts going away. And this is one of the typical signs that we see with people who have coronary disease, blocked arteries. That angina, that discomfort doesn't have to just occur in the red zone. Sometimes people get discomfort that kind of radiates to the shoulders and down the arms. More so than not is usually going down the left arm. Or you can have pain that's in the neck or radiating to the jaw. These are all signs that should raise an eyebrow. And depending on the severity of your symptoms, you should or should not go to the emergency room, depending on your severity. If you have severe symptoms, that heavy chest discomfort with other symptoms, the shortness of breath, the nausea, the sweatiness, you need to call 911 and go to the emergency room. But I answered a question earlier, hey, what if I have just some subtle pain, it goes away, and it just catches my attention? I would tell anybody, any discomfort in your chest needs to be evaluated because that could be a sign of something worse. And of course, people don't want to cry wolf too many times. However, you want to make sure that you have a thorough evaluation and that you don't miss or put your life in jeopardy for something that you had some warning signs for prior. So we talked about angina or angina, and I mentioned the typical way that happens is with exertion. You undergo some activity, whether it's mowing the lawn or you work at a construction site, you're actually doing some type of effort, and you start getting chest discomfort. That's represented by this schematic here. When you have a blocked artery, you have cholesterol buildup in the walls of the artery, and over time the vessel has narrowed. The blood supply has to squeeze through here. And so that's what's happening. Under normal circumstances where you're not exerting yourself, you still get enough blood flow through here to supply the heart muscle. But under situations where you have to exert yourself and you need to have a little more blood supply so that muscle, the heart is a muscle, so that muscle can function appropriately and increase its workload, you're not getting it because there's a blockage there. Now there's another type of angina we call it unstable angina. This can be symptoms at rest. And the way this happens is basically it's kind of the precursor of you having a full-blown heart attack where you've actually made a clot inside the vessel here. And that can happen at rest. So how is this diagnosed? Again, how do you know you're having a big one? And I employ you to say that there is no telltale signs that you are having a true heart attack at home. But you have to treat your symptoms as if you were, especially if they're of sudden onset and significant severity. And I would again implore you, if you're having subtle symptoms, something that just catches your attention, that you do seek medical attention via your primary care doctor or your cardiologist if you have one. But what we do from the medical side, we take a thorough history. We want to know if you have that trifecta: high blood pressure, diabetes, high cholesterol. We want to know if you have a family history, a brother who had significant heart disease, or a mother or father who's had significant heart disease, especially at an early age, that puts you at risk. We want to see what your EKG traces look like. We want the most effective thing from an EKG for us is to see one from previous and to see one of current, because that tells us over time has something changed. Some people have abnormal EKGs at baseline. Doesn't mean that you were born with a heart problem. It just means that by the standard textbook reading of the EKG is abnormal. However, if it's been abnormal for 50 years, it's pretty normal for you. So also, we want to check blood tests. If you're in an acute setting, you feel like you're having a heart attack, we check blood tests. One, there's a blood test to let us know that if damaged muscle has occurred, that we'll see portions of that damaged muscle floating around in your bloodstream, for instance. Or we want to check your cholesterol levels to see if you're at high risk for having heart disease. Check your diabetes levels to see if you're uncontrolled diabetes. Obviously, those people are at the highest risk for having heart attacks and chest pain. So this is what an electrocardiogram, an ECG or an EKG looks like. And of course, to people with untrained eye, you don't know what you're looking at, just some squiggly lines. But in my world, this person needs to go to the heart cath lab emergently. This is the sign of someone who's having a heart attack currently. And so this is what we would evaluate. And when you have a heart attack, people are familiar with the brain, and you have a stroke. A stroke and a heart attack are pretty much the same process in different organs. A stroke is a blocked artery in the brain. A heart attack is a blocked artery in the heart. And what happens is when that artery gets blocked, say for instance there's a blockage here, everything downstream dies. And so you have literally dead tissue in the heart that's not functioning well, and which can affect your overall heart function. You can develop congestive heart failure. And obviously in the acute setting, you can have severe chest discomfort. And again, I just spoke on this. It's a buildup of cholesterol and plaque within the vessel walls that makes the vessel narrow, and those blood cells can't get through. So we'll talk shortly or briefly on some of the treatment options. Medicine is an ever-changing practice. And so early in the early years, we used to have something what's called thrombolysis. So these are your clot-busting medications. It's rare that we use these days, and usually these are used in rural areas where people don't have access to angioplasty or a cath lab within 100-mile radius. And so they give you these clot-busting agents. Hopefully it goes in and dissolves the blood clot within the vessel, and restores blood flow. But obviously these don't come without risk. This is more potent medicine than the blood thinners that you've heard of, Coumadin and warfarin, or the newer ones, the Xarelto, the Eliquis, or the Pradaxa. This medicine is more potent, and you will only receive this in the hospital. But centers and across the country and cities have access to cath labs, and so most people go directly to having a heart catheterization and receiving what's called coronary angioplasty. And we'll show you later that basically angioplasty is where we go in with the balloon, inflate the balloon, open the vessel, and then place a stent there to keep the vessel open. The stent acts as a scaffold to the vessel and not let that cholesterol reaccumulate so fast. In worst case scenario, we do the heart cath and have an angiogram, and you have blockages in multiple areas of the heart, severe blockages. And that's when we'd recommend that you have the coronary artery bypass surgery. We know that people with multiple blockages do better in just having multiple stents placed and to have the bypass surgery. So this is a true angiogram of a patient that came to the hospital and was having a heart attack. And I think that most can appreciate that here there is pretty much almost 100% occlusion here. It's probably some thrombus in there. This person was probably having unstable angina and made a blood clot within the vessel. And so that needs to be addressed. In this schematic, we have multiple planes where we take those pictures, but this was the vessel here that had that blockage right there at the top here. It was the left anterior descending artery. And it comes here, but it goes all the way back up to this one. And so this comes off and bifurcates, and there's one that comes around the backside. You can see the shadow of it. Now the other coronary artery, the right coronary artery, comes off the aorta here, goes in this groove and gives off branches here. There's one that comes around and goes down the bottom part of the heart here. And again, we kind of show this schematic. I want to make sure I drive this point home, is that the cholesterol collects within the wall of the vessel, and then as things worsen, the cholesterol actually makes the lumen narrow. And so this is how the plaques form. And then over time, the people who actually develop unstable angina, we talk about plaque rupture or unstable plaque. And what happens is, if you think about say a boil on your skin, it's accumulating, it's all inflamed, it's got some infection in it, and then when it gets to a certain size and the skin kind of doesn't hold it anymore, it kind of bursts open, it ruptures. So the same thing can happen on the inside of the vessel. So this vessel, this plaque ruptures, and your cells within your body see that, hey, the skin's damaged here, we need to repair it. And so what happens if you're bleeding, you cut yourself on your skin, it makes a scab. Basically, your body starts making a scab inside the vessel to try and repair itself. And as it does, it occludes more blood, and it can actually occlude the whole vessel. And that's how you have that heart attack. So this whole territory downstream is jeopardized, and that's what causes a heart attack. So we talked about coronary stenting, or putting angioplasty or stents within the vessels. What we do is we start here from the artery. Our catheter goes up, and we are able to shoot dye within the artery here and kind of see where the blockage is. And so that's the procedure that we do. Now at this point, we're able to put a wire down that blockage here, and after that wire, inflate that balloon, kind of pushes all that cholesterol and plaque out of the way. And now, after we've had the vessel open, we come in with a stent, open that stent, and deflate the balloon and leave the stent there in place. And so that's the procedure of how we do these and what we're doing. Now, it's important for me to tell you that if you've had disease, you've had blockage in one spot of the heart, is obviously, if you make no changes, you can have more blockages in different arteries in the heart. So it's important that once we do this procedure and identify that you have disease, that you need to do something different. You need to exercise, you need to eat healthy, you need to lose the weight, need to stay away from all the fried foods, all the boudin and the crackling and all the things that partake in. So I did mention that over time you can have more blockages in the arteries of the heart. What we found is we have drug-coated stents. This is DES, drug-eluting stents. And what these drugs do, there are drugs attached to the struts of the stents. And you can see that the polymers of the drugs actually invade the cells or the layer of the tissue here. And that acts as a process to prevent that cholesterol and all that inflammation around that area to actually start returning. So we can put a stent here, but you can see the stent has open struts. So what's to say the cholesterol doesn't just start building up within the spaces of the stent? And so what the drug coating does, it helps prevent that. But over time, again, if nothing changes, then you'll go back to the same and actually continue to put blockages even through the struts of this stent. So I was tasked to bring you guys information on how do you know when this is the big one. And I'd go back to Red Fox and say, hey, he didn't know when he was having the big one, but he definitely let everybody else brought some attention to it. So if you're having chest discomfort, don't sit on it. If it's subtle, if it's something that can wait, definitely call your primary care doctor or your cardiologist and have it addressed. But if you're having significant discomfort, which is a subjective thing, some people would rate their pain a different level than someone else. So if it gets your attention, you need to get it addressed. If it's severe that you're having other symptoms, shortness of breath, nausea, vomiting, palpitations, any of these things, that's when you want to consider calling 911 and having it really addressed. So the ABCs of prevention, you want to avoid tobacco products, smoking. You want to become more active, and you want to choose a good, healthy diet. So that's where we want to get you off on a good foot there, to adopt a healthier lifestyle and lowering your risk for cardiovascular disease. And so these are the things that you need to do. We've mentioned these multiple times throughout. Stop smoking, good nutrition. You want to focus on that trifecta, reducing your blood cholesterol level, reducing your blood pressure levels, and having your diabetes controlled if such. And I think at this time we'll start our question and answer portion. And yes, sir.
Congestive heart failure, how does that differ from a heart attack?
So I kind of describe congestive heart failure in some points. It's what's left of the heart after you've had your heart attack, or a big one. Because as we see, a heart attack is basically when you have dead heart muscle. And so congestive heart failure is the heart is not squeezing well anymore because too much tissue has died and it's not able to keep up with the demands of your body. So you can have multiple symptoms, but mostly people complain of shortness of breath and fluid swelling. If you think about it, if the heart pumps the blood to the body, it's not able to keep up with the body's demand. And so you have a lack of oxygen to your organs, and you feel that. So you feel short of breath, and you can't function at what you used to. So people start limiting the amount of exercise or activity they do to accommodate for that. Yes, sir.
What about working out in the yard and you work pretty active and you get shortness of breath, you have to stop and take deep breaths. Seems like you're not getting enough oxygen, but you don't have any other discomfort.
Mm-hmm. That's still the definition of angina, where if you're exerting yourself, you're working in the yard, and you get significant shortness of breath that you have to stop. Now, you may not feel the discomfort, but that tells me that you could have a lack of oxygen, adequate oxygen to the heart muscle, and it's letting you know, hey, there's a problem. So if you continue, you may get to the point where you start having chest discomfort. But if you have significant shortness of breath, or dyspnea as we say. With exertion, that's equivalent to angina or chest pain. Yes, sir.
When you're exercising and you get pain in this area, mild pain, is that considered the same thing?
Well, it typically can, but what are you doing for exercise? Are you doing weightlifting?
No, treadmill.
Treadmill, okay.
You get slight pain in this area.
I would definitely get that evaluated as well, because again, that's something that occurs with exertion. And then if you stop, you get off the treadmill, and the pain slowly subsides and gets better, that's an exertional symptom that can be translated into significant coronary disease. So it's something you need to be evaluated for. Yes, sir. Yes, sir.
Is it common for stents as they get older to clog back up?
Absolutely, absolutely. We give you medicines to help keep the stents open. Aspirin, Plavix, there's some newer medications out, Effient, Brilinta. However, over time, the biggest risk factor we showed you on the screen was just advancing age. So if you had a stent placed 10 years ago, it's more likely that's going to have get re-stenosed or more blockage in it than someone who never had a stent.
Can you clean that out and put in another one, or what do you do?
So what we do is, if you get to the point where it starts having so much blockage in it that it, again, is limiting blood flow and there's a problem, we don't clean it out. We usually just go in, balloon it again, and put another stent on the inside of that one. So we've had people that had multiple stents inside of stents. Now there are some procedures where we actually go in, if it's very calcified and hard, there's a little spinning burr that we actually can put down the artery. So it's a little more tricky, and you generally don't do it if you've already had a stent there, because it can catch the metal strut on that stent and cause a major problem. Yes, sir.
You said that you go in with the balloon, do the strength, where you have the cholesterol and you have the plaque, and that pushes it out. Where does it go?
It doesn't push it out, it just pushes it to the side. It kind of just opens it up and just kind of opens the vessel. So it's still within the wall, but it's kind of just smushed to the side. And that's why we put the stent, acts as a scaffold, so it doesn't kind of recoil and gradually come back in.
So it's not removed, it's just placed in a more functional fashion.
Correct. Yes, sir.
5 bypasses last year. They took veins out of my leg and put it in my heart. There's no time limit on those. I mean, it's not as strong as the artery, I guess, the tissue. But they can last a long time, I guess, if I keep my diet well and exercise, I guess.
Correct. So in summarizing, he says he had bypass surgery. He had 5 bypasses, and he took the vein out of his leg, and he was concerned about how long does it last. He answered his question. They can last a very long time. People generally do well 10 years down the road, but over time you can accumulate blockages in the vein that they take out of your leg and put in your heart. He also adequately pointed out that it's a vein. The native vessels in your heart are arteries. They have a thicker muscle layer. Veins do not have a significant muscle layer within them, and so they can become damaged over time and are more prone to having these blockages. But you were born with these arteries, and it took them years to get blocked, whereas the veins, generally speaking, after 10 years, we start worrying about them getting blocked and kind of keep a closer eye on you.
To make you feel better, I had quadruple bypasses 24 years ago, and I'm still here.
There you go.
Some of them are clogged up. So.
Yeah.
Is it dissolvable over time?
The stents?
The plaque?
No. Once you have that plaque buildup, it doesn't dissolve over time. Our job is to actually prevent it from getting worse at that point. So after you have it, but with proper diet, exercise, and medication, we can prevent those blockages from getting worse.
Is there any technology that is
If there is, I need to get in from the ground floor up. I need to find that pill. So the answer to that is no, we don't have anything. You take this medicine and it dissolves all the cholesterol in your body. I don't know if that'd be a good thing. Right.
The cholesterol, even if it comes loose, might cause a problem. What do you do?
What?
If it comes loose, the cholesterol, if it dissolves, it'll cause a problem for you, won't it?
Well, I guess thinking about it, the cholesterol is within the wall of the vessel. And so if it were dissolved within the walls of the vessel, or say, for instance, if it kind of melts away, you'd have a huge elevation of cholesterol in your bloodstream. You may get pancreatitis and some other different problems with it. But of course, this is all theoretical, or we're just kind of thinking of what could be and possibly. But I'm sure it'd come with a whole host of other problems. Any other questions? Nope. All right, well, thank you guys for your time.